Thank you very much. Good morning, everyone. It's an honor and privilege to be here. This isn't exactly the type of talk I thought I'd come back and deliver my first grand rounds at UBC on, but it is a subject that I'm very excited about and very passionate about. First of all, Dr. Goldenberg, you've done a great job spending money. I love this room. I hope everyone's got their 3D glasses. And thank you for the cows. It's a nice effect also. My role this morning is twofold. I want to, first of all, take an academic approach to look at the Internet and the value of the Internet in healthcare as a learning tool, as a communication tool, and as a practice management tool. And I also want to introduce the concepts of patient-centered care and shared decision-making. And coming from a urologist perspective, this is not the kind of stuff you're used to hearing in your rounds every month or every week. And you may find this a bit of an odd topic, but that's why the Royal College calls it an unperceived need. I'm also going to introduce two new Internet-based products that I've been part of developing called MD Collaborate and MD Conversation. So just a few disclosures. I am the co-founder, partner, executive vice president, and editor-in-chief of MD Conversation, as well as MD Collaborate and a few other products. And my other disclosures are listed there for you. So let's talk about healthcare and the Internet in general. I think we all know this, but the Internet has deeply penetrated healthcare at all levels. Providers, patients, hospitals, government agencies, societies, and various other groups use the Internet every day, and it's becoming more and more a part of our daily practice. So how do physicians use the Internet? We use it in a variety of ways. We do online learning, online teaching, knowledge sharing, distance medicine, consulting, support, research, problem solving, communicating, marketing, commerce. We use databases, we share imaging, and we can even do remote surgical procedures now over the Internet. I'm just going to talk about a few of those uses as they pertain to the rest of my discussion. Online CME, online text, journal access, and research are all familiar learning tools, but we also use the Internet for quick problem solving with Google searches. We can do simulated learning, web conferencing, webcasting, collaboration, chat rooms, and now we use it in medical school and residency teaching as well. As far as online CME goes, there are multiple modalities to deliver online CME as we've listed. And there's increasing uptake of online CME across Canada. This was a survey from a couple of years ago, and the numbers have probably increased further since then. But at that time, somewhere between a quarter and a half of Canadian physicians had online CME available, and about 14 to 24% were using it regularly. And at least 50% of us use online journals and access other materials. There's been at least one randomized controlled trial, which was published in JAMA a couple of years ago, that demonstrated the value of online CME as far as knowledge retention goes. And they compared it to live CME and showed that in most cases it was at least as good, and in some cases it was better than live CME. So there's increasing evidence of the value of online CME. Obviously, there's still progress to make as far as developing the perfect ways to deliver it. Google is now officially a verb, and we all know that we can Google for topics very quickly and easily. According to something I read recently, we all carry about 2 million facts in our heads. Google, however, offers 3 billion articles within a second or less that we can access for information. If you haven't seen it already, there's a new product by Google called Google Scholar. It's in a beta version. It's available now if you want to check it out. And it offers only peer-reviewed articles, so it's trying to further penetrate the field of delivering health information. Google has already taken over from PubMed, apparently, as a search engine of choice for retrieving medical articles. This was an interesting article published just at the end of last year using Google to search for and solve diagnostic cases presented through the New England Journal. They reviewed 26 cases and used Google searches and found the correct diagnosis in 58 cases. They tried to pretend as though they didn't know much about the subject, and through Google they were still able to come up with the correct diagnosis in 15 out of 26 cases. So as well as learning, we use the internet as a communication tool as well. We use email, we collaborate, we can register for meetings and societies and whatnot, communicate with organizations like the Royal College web portal. We can do clinical trials on the internet, we can advertise if we choose. We can provide our own websites and do patient communication and education as well. Just a few words about email. We all use it, and generally it's very effective and it can be a secure form of communication, but it's not always a secure form of communication. Most email services are not encrypted, or if they do have encryption available, they don't offer it up front. You have to go finding it and enabling it. And even when the transmission is encrypted, the storage of the data may not be, and the user at the other end may not be obeying privacy and security as well. CMPA provides some guidelines on how to use email and communicate with it, and at all times we have to maintain privacy and confidentiality of communications when we're using email. There are many ways the internet can also be used as a practice management tool beyond communicating and learning. We can develop websites. We can have an EMR, which integrates with an electronic health record, or EHR. We can communicate and educate patients, deliver or manage non-insured services, deliver other products, market, use commercial applications, etc., etc. And I'm just going to focus on a couple aspects. First of all, if we implement change in our practice, for example, if we decide we want to have a website or introduce the internet into our medical practice, we first of all have to be clear on what we want out of a change, or any change for that matter, in medical practice. And generally we want one of three things. We want to either enhance our ability to deliver high quality care to patients, so improve health outcomes or improve patient satisfaction, or we might just want to enhance our balance sheets by increasing revenue or reducing expenses by improving efficiency in our practice, reducing waste in our practice. Or we may just want to enhance our enjoyment of our practice and our quality of life. So keep in mind that we spend most of our lives working, and for us working means working within a framework of a medical practice, and how our practice develops and operates can affect ourselves, our physical and mental health, our lifestyle, but also the people around us, our patients, our staff, and our family. And that's an important framework to keep in mind in introducing any changes to your practice. Briefly, physician websites can range from the simple to the complex. Simple ones are now offered for free through the CMA. They bought a company called mydoctor.ca and offer basic free websites for physicians. A basic website will have your name and address, your office hours, some contact information, referral information, as well as the services you provide and possibly information on uninsured services. Getting more advanced, you might want to post your CV to be downloaded. For example, if you're doing talks, you can do online forms, secure communication with patients and other doctors. You can do appointment scheduling, collaboration, patient education. You can provide links and resources and numerous other things. You can even do self-assessment through your own website. If you are considering setting up a website, some basic requirements are that you would have a simple and effective address or URL. The site should be professional and personal, preferably with some photos of yourself and your staff. You should update it regularly and ensure the accuracy of the information that you have on your site. The CMPA provides a legal disclaimer for physician websites, and that should be employed. And you should maintain, again, patient privacy at all times through a good policy of privacy. More advanced sites will introduce personal branding, logos, a nice look and feel to it. You can consider employing some interactive components such as a password-protected login or patient portal where you can communicate health information with patients, have them send photos. You can do scheduling, handle referrals, prescription refills, and bill non-insured services through such a system. A site might also provide accurate links to information, not just the information that you deal with, but you might provide support information. For example, my site provides links to support for smoking cessation, just as an example. There are many other products available that you can integrate into your website if you so choose as well. So how do we use the internet for patient communications? Well, research shows that generally patient communication is unsatisfying for both patients and physicians in the gap between visits. And the internet has a potential to help bridge that gap and improve the communications between visits. Many physicians, especially American physicians, use the internet to communicate directly with patients. A 2001 AUA Gallup survey showed that at that time, that was 6 years ago, 15% of urologists were using the internet to answer patient questions. Unfortunately, a third of them were answering questions from unknown patients or out-of-state patients, which is a litigation concern. But certainly there is a demand there to use the internet to communicate with patients. These numbers are now higher, and some states, if you comply with guidelines, will offer reimbursement for such communications. So potential advantages of using such communication are you can introduce convenience to your practice and improve your efficiency of workflow. You can save patients unnecessary visits, for example, especially with primary care providers with prescription refills, just as an example. People often have to take a half day off work just to get to their doctor's office to do a prescription refill, which can be done online in a few seconds. You also get a record of the interaction, which is an advantage over phone calls when it comes to internet communication. And there's the ability to introduce a new revenue stream to some practices. There are some concerns. Perceived concerns include the litigation concerns I mentioned earlier, some privacy issues, and the possibility of being overwhelmed with a large volume of messages. Along with those concerns, other potential barriers include the fact that we're not reimbursed for most of the activity, getting patients to use the system, patient fears for interrupting their physician, concern about not reaching the physician directly and working through an office staff who handles the email or communication, and also just how best to implement such a system. There have been some studies that show that such communication systems, though developed into a physician website, can be successful in improving patient satisfaction with communication and overall care. This is from a couple family practice studies, but it does show that generally patients feel that it saves them unnecessary visits and phone calls to the office, and many of them find it convenient because they can access the communication system after hours. In these studies, the volume of incoming messages was not extreme, and it was very easy to use for the physician. Patients have also underscored the value of such systems by stating a willingness to actually pay for the service. If we do introduce such communication systems into our practice, we need to keep a few things in mind. We have to clearly define and communicate the limits of such communications. For example, what information will and will not be communicated, who will do the communication, whether it's the physician or the staff member, which patient should be allowed to communicate, the time limits in which you will respond, and alternative forms of communication that are available to patients if they choose not to use the system. If you use email, again, use an encrypted service, and if you use your website, you'll need to either develop or use a third-party secured portal system. It's helpful to develop frequently asked question pages to facilitate and make things even more convenient for you. For the sake of time, I'm going to skip over a bit of this. I did have a few words about electronic medical records. I'm not sure what your experience is for all of you with electronic medical records, but I've been deep into this process over the last few years. In Alberta, there's a strong move towards using electronic medical records. And compared to the States, where about 20 to 25% of physicians overall use one, in Alberta now 61% of physicians, that's 3,369 physicians, are signed up in our EMR program. And there are different levels of funding in this EMR program, but interestingly, 83% of the ones in Alberta are using the full EMR, so absolutely no paper records. There are many stated benefits according to the AMA website. One interesting note that I got from the website is that it states that the funding they've provided for the EMR and the investment they've made is to benefit the patient and the health system and not the physician. That's not to say that EMRs don't benefit physicians. I've found it very beneficial, and I'm a strong advocate of it. EMRs are meant to be an integral part of a provincial electronic health record, and the concept there is that certain pieces of data from your EMR will transmit up to the electronic health record, so that when a patient goes to see another physician, there are certain pieces of information they can access to avoid duplicating services unnecessarily, such as lab work or imaging tests, and to avoid overprescribing medications, for example. So initially we're looking at centralizing some data about prescriptions and lab work, and then eventually moving to other diagnostic tests and imaging, etc. So having said that, I'm just going to skip over a couple of things here. I have to say that I find there are a lot of progress to be made still in EMRs. There's too many vendors. There's a lot of rules which vary from region to region, so you have regional vendors rather than national vendors. I find they're exceptionally good at sales, and in some cases the support is not there as it should be. So there's a lot of work that still needs to be done with an EMR. Further consolidation will occur in the market, and there needs to be better products to satisfy both our needs and the needs of the health authorities. Having said that, I wouldn't practice without it. I've found that EMRs have dramatically improved the karma within my office. I don't have to drag charts around. I have a portable office everywhere I go. I never have to worry about having my office emergently fax papers to me or something, because it's all just available through the internet, through my EMR. Interestingly, if you read the financial news just a couple days ago, Microsoft just bought an EMR company, a startup company, and Microsoft's blog states that they look at healthcare as being the most exciting thing they've seen in many years. And many years in the technology world is like centuries. Okay, how do patients use the internet? Well, we know that patients use it to educate themselves. They also can find decision-making tools such as Parton tables, for example. They can find drug information or get prescriptions even in some cases. They go doctor shopping. They fill out health questionnaires. And, of course, they act as a set of eyes for all the greedy advertisers out there. Apparently, about 8 out of 10 Internet users use the Internet to seek healthcare information. It is the third most popular activity after email and researching products and services. The term cyberchondriacs was actually developed to define these patients that spend an inordinate amount of time researching health information about their perceived health problems. As an exercise, I just a few days ago did a Google search on prostatitis just to see what it was like from the patient perspective. In 0.4 seconds, I was referenced 1.95 million articles. The top 10 sites came up with 8 reasonably quality sites that were referenced and 2 fairly sketchy sites. There were also 9 ads on the page. And here's what the page looks like. You'll see on the right you have all these advertisements. If you didn't recognize them as ads, of course, you would find yourself down a winding road to various products. The top site actually turns out to be the Prostatitis Foundation, and when you link on there, you get to this fairly unattractive site, which you can't read, but it basically says, we're not going to tell you what to think. Feel free to view the 250 pages that this site links to. Now, I clicked on the bottom right there where it says treatment for prostatitis because it seemed to attract me to go there. And I got to another unattractive site. I clicked on prostatitis there, and I got to 2 advertisements, one for ProstaQ and one for the Theraseat. So this is kind of an unfair example, but the bottom line, this was the top site listed on the Google search, and that's the kind of things that our patients face. We can navigate through them without any difficulty, and a lot of our patients are fairly sophisticated consumers. They can as well. But not everyone can, and it certainly can be a time-consuming affair to to go through all these links. So the bottom line, there's a growing number of patients who use the internet to find health information. There's abundance of good information available, and most sites do provide conventional information, but not all of them do, and left to their own, patients may not always find applicable information. The information also may be incomplete, irrelevant, or too basic. It may be biased from conflicts of interest not being stated. It may reflect regional practices or proprietary materials. Information often lacks scientific vigor, and in one study, up to 71% of material on the internet was not referenced. And it can also be misleading because information can be posted from anyone, anywhere, anytime. From our viewpoint, we generally have a negative view towards this. Just to quote a couple studies, about 41% of physicians said that patients who conducted internet research were misinformed. There was a qualitative study of some family doctors in the Toronto area, which generally showed a negative view towards patients who used the internet, and they felt unprepared to handle these types of consults. They felt that it added a burden to their responsibilities where they had to sift through information, explain to patients why the information was misleading, and this in turn can lead to mistrust between the physician and patient and dissatisfaction. So turning things around, how can we use the internet to educate patients rather than vice versa? Firstly, why educate patients in the first place? Well, we know that knowledge empowers patients to be more engaged in their treatment decisions, and we call this patient-centered care. Education can also improve compliance with treatment, both preventative measures and conservative measures, as well as medications, and this has been shown in a number of studies. And the end result, ideally, would be improved health outcomes. We should also educate patients because we know that they want to be educated. This landmark study by Davison and Goldenberg et al., published in the British Journal of Urology, looked at 200 patients with localized prostate cancer and their views on education towards sexual function. 84% of them had received already some information on ED as an example, but no less than 61% still wanted more information. And written information on the internet were the preferred media. There are many ways, many platforms we can use to educate them. There's written text, the internet, of course, videos, and more labor-intensive physician visits and nurse visits, etc. And while all of these have limitations, the internet probably has the greatest opportunity to do a good job with this. There are many challenges as well, both from the physician side and the patient side. We all come in with different attitudes, languages, ethnicity, education. Patients have a lot of anxiety often that will affect their ability to be educated or their want to be educated. And then on top of that, we have to be able to understand each other, communicate with one another, listen to one another, and disclose our concerns to one another. So the internet has the opportunity to provide efficient delivery of information. There's universal access. It can be delivered in multimedia fashion. It's flexible in terms of the literacy level you can provide and the language you can provide it in. The effectiveness can be tracked and evaluated. It is space efficient and environmentally friendly. Just a few brief words on patient-centered care. This is a very hot topic amongst medical academics, bureaucrats, and the Royal College, so don't shy away from it. It's a fairly simple concept, but it's being introduced more and more intensively in the medical community. Basically, it emphasizes communicating with and educating patients to take a more active role in their health care and decisions. And this whole process evolved in conjunction with a move amongst medical ethics to move towards patient autonomy over paternalism. And interestingly, you'll also note that the development of this parallels the development of the internet and the so-called information age. So I think as we move towards this concept of healthcare, the internet will obviously play a very important role. And basically, patient-centered care involves effectively communicating quality information between patients and physicians, allowing them to make shared decisions, and all of this is encompassed within the realm of patient-centered care. Shared decision-making is another buzz term that you should be familiar with. And there are a few key points about shared decision-making. First of all, this is just one component of patient-centered care. It's not a necessary component of patient-centered care because obviously there are situations where it's not applicable to go through a shared decision-making process with a patient in an acute situation, for example, or if the patient just does not want to partake that way. There's limited evidence, actually, of the effectiveness of this process to date. It does improve patient satisfaction, but whether it improves health outcomes in the long run is yet to be proven. However, as I said, it is a hot topic and greatly desired by government and health authorities. Just as an example to show you the writing on the wall here, the third one down here, the Institute of Medicine did a large study and identified patient-centered care as one of its top recommendations to improving the U.S. healthcare system. So that's a fairly strong statement. And Senator Kirby's report in 2002 on the health of Canadians and the Canadian healthcare system also recommended that Canada's publicly funded system be patient-orientated. As an example, in Calgary, the CHR has developed what's called Patient and Family-Centered Care Initiative, and I know firsthand that they're pouring a lot of resources into developing this. And the Vancouver Coastal Health Authority is also promoting their continuum of care, which is another patient-centered care model. This slide is busy. Just understand that delivering care is a stepwise process. We basically formulate relationships with patients. We try to understand what their problem is, make a diagnosis, reach some kind of decision on how we're going to treat them, and then treat them. And at every step of the way, the model is that there will be communication between patients and physicians that allows us to gather the best information and move stepwise through the process. The other important point here is in the blue boxes I've listed the tools that might be used in each of these steps, and you'll see that the internet can be used as a tool in every step along the way, particularly when it comes to making treatment decisions. So patient-centered care is a partnership provided through improved patient-provider relationships and communication, educational materials, and self-management tools. And this is basically the background as to why. This is a long way of giving you some background as to why I developed the tools that I'm going to show you in a minute. Ultimately, what would be needed to deliver patient-centered care effectively is a system that provides quality education to patients that's evidence-based and peer-reviewed. Physicians should be familiar with the information and understands it. It should be affordable, widely available, and accessible. And use of it needs to fit within the physician's framework of reference and their comfort zone. It should require little additional manpower to use it, and it should provide the physician with some feedback and some data regarding its use and effectiveness. We're almost at the end of this, bear with me. But this is basically the policymaker's vision of patient-centered care. Effective communication and collaboration can be facilitated by the internet and other tools, such as providing patients with credible information, decision-making support tools, self-management tools, and providing the physician with evidence-based knowledge. All of this leads to better collaboration. That leads to shared decision-making, which ultimately would hopefully lead to improved health outcomes and optimized healthcare delivery. My vision of things, if we're going to use the internet effectively, is that we basically need to take greater use of physician websites and provide services that work through physicians' websites. For example, right now the EMRs will not link to your website, and basically that is a big I think that is a big barrier towards us really moving ahead in this field, because ultimately we want to be able to improve efficiency in our practice, and if we can't automatically populate our EMR, for example, with information through our website, for example, the patient can provide at home through a secure portal, then the EMR is just a little bit cumbersome that way. So right now we have to use a multitude of different applications. We have a website and someone helping us with our website, and then we have an EMR, and we have a separate IT person for that. And we have third-party applications that we use, that we get through commercial places in the internet. We have the CME, and We've got to interact with the Royal College and everything else. If we could ultimately be able to link things through our website, that would be ideal. Then we could communicate with patients back and forth through a secure web portal. We could provide them services such as information, decision-making tools, etc. In return, they can provide us with demographic information, feedback, self-assessment data, etc., that automatically populates our chart through our website. And then through the system, we can also communicate with the outside world. Data can be extrapolated from our EMR to the EHR, which makes the government happy. Our CME activity would be automatically tracked to the Royal College without having to do it manually, and we could communicate and collaborate with the medical community in general and the World Wide Web. Just some final words of caution. Having said all of this, don't think that the Internet replaces anyone. The physician still maintains a central and vital role in making decisions for many patients. There's no substitute for understanding and communicating well with patients. And tools like the Internet can be powerful, but are not things to be hid behind. They need to be used selectively to enhance what we're doing, and they should be customized to meet patient needs and our needs. Finally, just as a caveat about this patient-centered care model, not all patients want to be informed, and you need to be able to recognize those patients. And patient autonomy and decision-making is not always the best thing, as you know. So in conclusion, the Internet has evolved. It's more accessible, affordable, it's faster. You have good applications and great interfacing. It's proven itself as an efficient way to deliver information, and it's very popular. But the vast potential of the Internet to actually make a difference in healthcare is only just beginning to be realized and tapped. And I'm sure that Bill Gates will go a long way to do that. When considering utilizing the Internet to enhance your practice, consider your goals. Try to pair them with your comfort level, but progress and take advantage of the opportunities that are offered. We've discussed the key components such as websites, communication, patient education, and the EMRs. Maintain privacy, security, and the quality of information as your top priorities. Patient-centered care is becoming more prominent in the practice of healthcare. The writing is on the wall. Performance-based reimbursement contracts are already being introduced in the United States and the UK, and they are on the horizon for Canada. And as we move to this model, patients will demand greater material that needs to be effective and credible information. We have two options at this point. We can either be reactive with patients. We can deal with them on a case-by-case basis, sift through the information that they've looked at, and try to help them understand what's good and what's not good. Or we can be proactive by providing them with websites that we consider credible to use in certain situations, or by producing the information ourselves, or by using a third-party service. And at a minimum, as stated at the AUA meeting opening address by the Surgeon General Everett Koop, at a minimum, we must remind patients that the correct information and incorrect information both glow on the computer screen with the exact same intensity. So that's it for this part of the presentation. I did provide you with some references if you're interested. And now I want to provide a demonstration of these products that we've mentioned. Any questions at that point? Or yeah.
Changing the face-to-face interface with patients to a internet-based interface with patients has a lot of potential. But one of the things that is holding it back is remuneration.
Uh-huh.
So, what are the steps that you think are needed to be able to overcome that, so that we can change the way we interface with patients?
Well, as far as remuneration goes, we are working in Alberta with the Alberta Medical Association, the Physician Association groups to try and clarify what type of communication can be reimbursed. Presently in Alberta, we are paid for taking phone calls to collaborate with physicians, and we can do that online actually through the system I'm going to show, and actually be reimbursed for it. Patient communication, though, remains limited, and we're trying to work with our provincial bodies to understand what communications we might be able to be reimbursed for. Right now, there are certain things like prescription refills that fall outside of insured services, and so those can clearly be done through a secure internet system outside of the insured services. But as far as reimbursement for a consult or for basic information, that is a barrier right now, and what we're trying to do is introduce what can be introduced now, and in an ongoing process, we're working with our government bodies to try and better define and hopefully lead the way in defining what kind of communication we might be able to make reimbursable. There are physician groups in Calgary, for example, that work on a health contract rather than a fee-for-service basis, and they do a fair bit of communicating online, and it just falls within that model of their reimbursement. So that's a whole different scenario. But if we're thinking just on the fee-for-service basis, we have some work and some negotiating to do, and we have to prove our value. But in that other model, it's a no-brainer. If you're on a contract basis for a certain population, then you want to introduce as much of this type of service as possible. Yes?
Hey, just a pretty vague question about electronic medical records. Do you have any words of advice for residents or people that are going to practice in the next couple of years as far as electronic medical records? When we get in, should we be getting in from the start, or should we wait for the right program, or any?
I would definitely advise you to get in immediately. The perfect system's not there, but if you wait for it, you'll wait a long time. And if you get into it immediately, you never get into any other habits. You get into the habit of electronic records, and you'll just evolve as they evolve. And I'm sure through my career I'll go to multiple EMR products, but that's okay. But I would definitely recommend going in immediately. Rich Baverstock, my office partner, did that as soon as he arrived. That's when we went to an EMR, and he would never look back. As much as we complain about our particular EMR, we still would never go back from it.
I'm not sure if you can answer this at this point, but do you have any idea of how easy it is now or going to be in terms of transferring patient information from one program to another as you evolve?
Well, right now, basically, it can't be done as far as I can tell. I mean, it's easy to be done, but you have to work with each individual vendor. They have to actually share code, which is the limitation. They don't want to be running around sharing code with people. It's very time-consuming for them. So I think basically, I don't know what the timing is, but there just basically has to be more consolidation in the market, I think, and some changes in how to deliver things. And I will say that I will disclose that in the background with the stuff that we're doing, we're working towards this ultimate model, which is all web-based. It's another problem with the current EMR programs. A lot of them are not web-based. Most of them, actually, they're based on hardware on servers that you have to maintain in your office and put a lot of time into supporting. So the first thing is you need more web-based products. Secondly, you need some consolidation, and then you need people to start sharing code. And I think what you really need is you need the people that are providing websites to be the same people that are providing EMRs. Yeah. It's a great way to get some exercise in the morning.
The other issue that we're dealing with is those patients coming to your clinic, they have downloaded a bunch of information from the internet. A lot of them are incorrect, and it gives us more grief doing a consultation with these patients. In our practice, prime example was undescended testis in pediatric urology.
Mm-hmm.
So Andrew and I actually went back and looked at all the sites that provide information with about this, and actually it's going to be published soon in Do Not Pediatric Surgery. One important thing that we found was the quality of the sites that are owned by university and also that are HO and accredited are much better. So I think we should take that into account. Not all the websites are good, and as you said, direct these patients. And probably HON approval is probably one of the best.
Yeah. And
do you know any other way that you can actually tell these patients which website to look at? Yeah. Because they're going to go wander around in the cyberspace.
Yeah. Well, my viewpoint is that we, as I said, we need to be as proactive as possible. And as I mentioned, I even will be directing patients to information before they see me for the first time. So I'm trying to be extremely proactive with it. But there are services and there are groups of people and academics out there that are developing the exact kind of tools that you're talking about, and those will become more widely available, I think. I don't have any specific information to give you on that, but there's a lot of interest in exactly what you're talking about, and it's just a matter of time before that area also gets further defined. All right, last question. I'm going to have to do a bit of a demo here. So, yeah.
Just one thing. How do you recommend that we direct patients? You probably direct them to your website.
Yeah.
And we should probably, other people can have our own website. I could give a piece of paper.
Yeah.
The one thing also I wanted to mention too is I'm on the patient information committee at the CUA, and we recently just met, and we are developing a website for the CUA. So it's going to be separate from the CUA website, but it's going to be separately just for patients. And they're not going to reinvent the wheels. So they're not going to have right from scratch what each of the things are, but it's going to be links to sites that have all been vetted by a committee saying that these are sites that have been quote unquote approved by the CUA, and that's supposedly coming out in about a year and a half or so.
Okay. Well, I think that's excellent. I will also disclose that we are already working and fairly deep into developing a partnership with the CUA, and I will be, and I'm in talks with the CUA to actually use this service as their online patient education service. So hopefully that will develop. But as far as the links and stuff go, I think if you develop print material in your office, for example, if you look at your top 20 conditions that you deal with, you should do a literature search yourself. You should find some sites that you think are appropriate, and those should be listed on your print information or given to patients, so you know, because it's not going to be the same site for every condition either. Once the COA provides it, then we're off to the races. But for now, each physician would be responsible for doing that himself. Let me talk briefly about mdconversation. Some of the people in the audience are familiar with using it, and basically it's a web-based service. It's meant to benefit all players in the healthcare system. I'm just going to skip to a demonstration. It was basically founded, as Dr. Goldenberg mentioned, in 2004. And it has several components. There's patient education available online, as well as questionnaires such as the IPSS, ICIQ, and various others are done through the system online. There's a communication feature and a tracking service. CME has now become available online through the system, and people who use the service also have access to, I think, probably developing to be the single best source of medical illustrations, not detailed Netter-type illustrations, but user-friendly illustrations on the Internet. The patient education material is delivered as a high-quality audiovisual presentation that can be accessed the same on low or high bandwidth. It doesn't contain videos because we don't want people with low bandwidth to not be able to access them well. Importantly, these are written by physicians. Most of them have been written by myself. They're peer-reviewed. They're independently produced without any proprietary input into the material. And the material is prescribed to patients, so there's a direct link between the patient and physician, and the patient hopefully is only directed to information that's pertinent to their needs. It's password protected and available in multiple languages. And what you get is what the patient sees is a nice, friendly, unbranded interface that has a streamed PowerPoint presentation. They can't download this. It's streamed over the internet. And on the left, there's a player that they can use to stop or go. There's a voice that's speaking to them and talking to them through each of these slides. There's almost no buffering time when they read it, so they can skip through this back and forth at regular speed. They can stop it. They can answer or ask questions through the system. And they also, down in the bottom left, they can see how far along they are into each presentation and how far they still have to go in the presentation. So a lot of patients log in, see that it's a 20-minute presentation, step out and come back in later. Questionnaires I'll talk about briefly. There's also a communication and tracking system, so patients, again, can click on a help button. They can type in a question. It's not an email response, and you can choose to enable that or disable that part of the system. You get a tracked records report through the system that details the activity of every patient. So this is useful not only as feedback for yourself about who's using it, what material they're seeing, but presumably it will have some ability to help us manage our liability as well. The CME presentations, again, are also high-quality audiovisual presentations. They're tracked and have an interactive component available, and we can offer them at a fairly low delivery cost. This gives you an example of some of the illustrations that are available through the image library. Again, there are more than 1,000 illustrations now in urology alone, I think, and these are all available to anyone using the service. So if you're doing talks or if you want to use these outside of the system to illustrate things to patients, there's a huge resource there available to you. And this is one of the things I'm most proud about this whole system. I've spent a lot of time. I've overseen the development of every one of these illustrations with 3 full-time medical illustrators and animators. The patient and physician benefits are as described in the earlier part of the presentation. But basically, we think that there's potential here to add value to the system in general and work towards this goal of patient-centered care. Last year, with an incomplete urology library, I had 600 patients use the system, and on average, they viewed it more than 2 times, and the average view time was about 11.7 minutes. And if you take out the people who just went in, looked at it, and came back later, the average view time is actually 20.4 minutes, which is incredible data. That's incredible retention time for a website compared to typical sites that people have surveyed. And of all these patients, we've only had 8 of them ask a total of 9 questions through the system. So Rich and I use this system not only, as I mentioned, prior to initial consults, but at each phase along the continuum of care as we talk to patients. We give them diagnostic data. We give them information about their diagnosis, information about conservative ways to treat their problem, information about their upcoming cystoscopy or urodynamics, full informed consent discussions about surgical procedures as well. And then, of course, we also use the image library and hopefully the CME. And what we've done to try and simplify this and bring it into the physician framework is we've printed off the list of modules that are available or going to be available onto prescription pads. These are just kept in your examining room as you would a brochure, for example. And when you see a patient and you decide they need certain material, you just check off what they need, hand them the paper, they take it to your receptionist, and she logs them into the system. So the patient then sits down with your administrator. It takes her about 30 seconds to create a new patient and put them into the system. And she prints off an instruction sheet with their login identification, and away they go. They can look at this at home or at a friend's house. I also keep a kiosk in my office with a set of headphones where they can sit down and look at the presentations there if it's more convenient for them. How are we doing for time? Are we a couple minutes? Okay. Ironically, this is a webcast presentation, so I can't do a live internet demonstration of the product. So I'll give you a virtual tour of the product through some screenshots. This is the home page, and physicians would go here to mdconversation.com. They would click on the patient button. They would have to read a terms of use agreement, typical disclaimer, and then they go in, and what they see are these are all blank. They've been handed a sheet that has the doctor code and their patient code. They enter those, and these are the presentations that have been entered into the system for them to see. So there may be one, there may be several. It's whatever you think at that time is appropriate for the patient. As they go through their care, they will have more and more modules linked to them. They'll stay up there for a certain amount of time, for example, 3 months, and then they'll fall off the system. But in that time, they can look at it as many times as they wish. Physicians can go into the physician site. I don't have a screenshot of that, but basically there's 4 areas that they can choose from inside the physician page. There's patient administration. They can go in and view presentations. They can look at reports or look at CME. And this is an example of the patient administration area. It takes just a few seconds to set up a new patient. They're assigned a code. Then you just simply click on the presentations that you want that patient to see, and it's assigned to them. This is an example of the records report. And what you see here is the patients on the left, the number of times they've used the system, whether they've asked a question or not, and the last time they accessed it. If you then click on one of those patients, you get a more detailed report. For example, this patient looked at the lithotripsy module 4 times. The first time, they looked at it right through, slide 1 to 38 in succession. It took them 20 minutes, almost 21 minutes. They asked one question, which I viewed already, and that was their access time. And then as they've gone in and looked at it later, they've gone more specifically to certain slides. So I'll be honest with you, I don't go back and look at this information with all my patients. That would take a lot of time, but it's there if I ever need it. If there's ever a question about whether they've looked at something, it's always there if I need it. And when patients view questionnaires, their data is also tracked in the system, and if they look at it more than once, you can graph their data over time. And again, in the patient presentation area, you can go in and review any module at any time as a physician. Whatever modules you have access to, you can go in and take a look at them. We do encourage people to look through them to make sure they're comfortable with the information, especially the ones that you're commonly using. And finally, this is the image library. There are hundreds of clip art drawings as well as numerous medical drawings as well. And again, just a sample of the number of drawings we're looking at. This is just one folder on radical prostatectomy. Last word, we do have several editors and advisors working with us, and this is growing. We have numerous advisors and people who've done editing for us in Canada, and now a growing number in the U.S. as well. Do you want me to stop there? Or?
Can you do this in 1 minute?
Yeah, I can do this in 1 minute.
I think you guys would be interested in this.
Sure. So MD Collaborate is another system we developed. This is more on the another practice management tool that basically this is a secure portal for communication and collaboration between physicians and between physician and patient. This allows also for secure online provision of non-insured services that we were discussing earlier, like prescription refills, insurance forms. I run all my medical legal work through here. I bill my VAS reversals and those types of consults through here. Anything that's uninsured, I run it through here. No more handling of checks. It's all done online with visas. This system has multimedia capability. Responses can be typed or dictated on the collaboration side, so it's a little bit more convenient. If you don't like to type, you can just dictate responses. And all the activity is tracked, and you get reports and billing information. This is what the home page looks like. It is secure, password protected and secured system, so you have to log in. once you log in, you have several tabs at the top there. If you go into collaborations, you can view ongoing collaborations that you have with other physicians or patients, or you can set up a new collaboration. If you go into the physician area, you can see that there's other physicians in the system. It is a little more efficient if you're collaborating with other physicians in the system, but you can still collaborate even with patients that aren't already logged in as users in the system. And finally, if you go into My Profile, you can go in and customize services that you provide through the system. In this case, this lists some uninsured services that someone might provide, and you can put detailed information in there. For example, if you're doing prescription refills, you can make it so the patient has to enter their pharmacy, name of their pharmacy and their phone number and that sort of thing, just to save your office staff time. So that's just a very brief look at MD Collaborate, which is a much more involved platform than that, but it gives you a brief idea. So thank you very much.